Good afternoon, or good morning in some cases, including for one of our speakers, as the case may be. I suppose it could even be good evening, depending on where you are. But thank you for joining us, and welcome to a special event being hosted by the American Association of Aerosol Research. AAAR is a nonprofit professional organization for scientists and engineers who wish to promote and communicate technical advances in the field of aerosol research. My name is Jim Cudahy. I'm a senior consultant with Virtual Inc., but I am certainly not the star of the show today. We work with AAAR to manage their business functions, and it's in that capacity that we're here today. It goes without saying that aerosol science has taken on outsized significance this year as our nation and our world have dealt with the realities imposed upon us by a global pandemic. Indeed, this week, AAAR is holding its 38th annual conference, but is doing so for the first time in an entirely online format. As part of this week's activities, AAAR thought it would be helpful if we could arrange a presentation by some of the leading authorities in aerosol science, doing so for the news media in particular. Our hope is to frame the key issues and dynamics that are relevant for the general population so that the media in turn can explain those dynamics to your readers, your viewers, your listeners. In short, the information you're about to see and hear in the proper hands can save lives. In a moment, I will introduce our three presenters who have graciously agreed to join us today. Each will deliver remarks for several minutes. After that, we will give you an opportunity to ask questions of one of the participants, of all three our speakers. You can do so either by using the raise hand function in Zoom, and we'll unmute you to ask your question verbally, or you can feel free to type your question directly in the chat function. Or if you're somewhat Zoom illiterate as I am, you can type in the chat that you want to ask your question, and then we will unmute you. If you have follow-up questions after the press conference, you can feel free to reach out to us at AAAR at Virtual, and we'll put you in touch with the appropriate person and appropriate speakers. Okay, with that, let me introduce our speakers. We're going to be going in, we won't be going in this order, but no, let me do it in the order. Jose Luis Jiminez is Professor of Chemistry and Fellow of the Cooperative Institute for Research in Environmental Sciences at University of Colorado. Linsey Marr is the Charles P. Lunsford Professor within the Civil and Environmental Engineering at Virginia Tech. And Shelly Miller is Professor of Mechanical Engineering within the College of Engineering and Applied Science, also at the University of Colorado. So with that, we first will turn the program over to Jose.
You need to stop sharing your screen so it allows me to share mine. Great. Okay, thank you. So hopefully you can see and hear me, see my screen and hear me. So I'm gonna introduce first about what we know about the modes of transmission, and which will set up some of the information to understand the later presentations. Okay, 1 second here. Okay, so we know this virus can be transmitted through surfaces, but that's not very efficient. So we are left with two modes of transmission through the air, which are thought to account for most of transmission. And in this figure, we can see them. And one of them is what we're going to call the ballistic drops, which follow a path like this, like Angry Birds, fly from one person to another, and they infect by impacting on the eyes, the nose, or the mouth of the susceptible person. And then we also have aerosols, which are smaller particles of different sizes that float in the air, and they are going to infect by being inhaled. Okay. So these are the two types of particles that are being debated about which one is more important. WHO and still CDC, although CDC has moderated their stance, they tell us that the large droplets, these ballistic droplets, is what dominates, right? And this is from a WHO video showing how these droplets are flying from one person to the other, and that can lead to infection. But if the people are further, then infection doesn't resolve because the droplets fall to the ground. I'm gonna argue that that's incorrect, that the evidence argues otherwise, that really, when we look at many different pieces of evidence listed here, which we're writing into our publication, The droplets have the least evidence, and they actually have some evidence against, while aerosols have the most evidence by far, and surfaces are in between. Okay? And I'm going to very briefly talk about two of the types of evidence. One is the fact that we see a lot less transmission outdoors than indoors. So it stands to reason if you have a projectile that can reach one person, that has enough inertia to travel in the air, that's not going to be very much affected whether you are indoors or outdoors. It's going to be similar. So if droplets dominated, we would go outdoors and transmission would be similar. If it was 50-50, transmission would go down a factor of 2. If aerosols dominated, because aerosols are like smoke, they are carried out by the wind or they rise and they are no longer trapped by the ceiling, then transmission would go down a lot, which is something we see. There is other evidence, like for example, aerosol transmission has been demonstrated for animal models and many other things that I don't have time to go into. I'm going to talk then about super spreading events, and in particular, the case of the Skagit Choir, which is a study that was published recently in collaboration led by Professor Miller and in collaboration also with Professor Marr. The article is available here. This is a picture of a generic choir, not of we don't have pictures of the actual choir. In reality, in our choir of interest, people were more separated. Basically, only every other person was present. In this case, there was a choir rehearsal for 2.5 hours, and there was one person that was later known was sick at the time, and 52 new infections resulted, including people who were 13 meters or 44 feet behind the index case. When we look at the evidence from the event and we look at the surfaces, we see that everyone agrees that getting infected through surfaces is inefficient. And we know that the index case, basically, the only thing they touch was a bathroom where only 3 other people went. So it's impossible that they could have infected 52 people that way. When we look at these ballistic droplets, CDC tells us you need to talk to someone for 15 minutes to have a chance of impacting enough droplets on other people's eyes. But in this case, the index case didn't talk to anyone or almost anyone. And other people only talked to about 2 to 3 people because they only had a 10-minute break. So again, we can rule out fomites and droplets, and this has to be explained by aerosols. And it's easy to explain. It was a room that had low ventilation, that was well mixed by the heat of the people. They were not wearing masks. It was a long time, and they were singing, which we know greatly enhances the production of aerosols, right? And when we analyze this super spreading event, we see that the amount of virus this person was putting in the air was about 10 times as much as the famous bus and restaurant cases, which is consistent with the fact that they were singing all the time versus talking intermittently. So it's a pretty clear case. So now there are many other super spreading events, and the question is what causes super spreading? And I don't think anybody knows, but this is a paper that Professor Miller found that I think is very useful to think about. It is the wrong person in the wrong place and the wrong time. So we know in this graph, this is kind of how effective someone is as a function of time in the disease. So people are most effective just before they start having symptoms and just as they're having symptoms. People who are very sick in the hospital are not very effective, right? So then for a super spreading event, you need to have someone who's kind of at this peak of infectivity just before they have symptoms probably, and who happens to attend an event where a lot of people are present and an activity in a low ventilated environment and an activity that favors like a lot of vocalization or singing that favors putting people into the air, right? So this is what this graph represents, is like this is how much virus the person may has, and this is how many people they may be in contact with for how long. So you kind of have a sweet spot of conditions that lead to super spread. But then if the person wasn't in contact with a lot of people or they were not very effective, then you don't have super spread. And this causes this disease to be very explosive at times and then boring a lot of the time and not leading to transmission. So then once I've argued aerosols dominate, I think we have to think about this observation that social distance works, which is the reason why a lot of people feel droplets are important. But this can also be explained by aerosols. Like if you look at the smoke, which is another exhale aerosol that also doesn't fall to the ground, if you're talking to this person close by, you're going to be inhaling a lot of exhale breath with very little dilution. In room air, if there is low ventilation, you can also get infected, but it's going to take a while and you need to have low ventilation because the smoke level has to build up. Okay. And since I'm going a little long, I'm going to skip a couple of things. Okay. So, and then basically, what I'd like to say, why we're in a situation where WHO, for example, is so adamant that aerosols are not important, while we think they are very important. I think it's because of history. There was a hypothesis put forward in 1910 that aerosol transmission was very difficult and droplet transmission dominated, really without evidence, but that became the established paradigm, right? And we see through the history of the 20th century that even diseases like measles that now are completely accepted as a terrifying airborne disease, as recently as 35 years ago, it was described as a droplet disease because it transmitted very well in close proximity, right? And there were cases in which they said, well, and it cannot be aerosol because there are cases in which people with measles are sharing the air with other people and people don't get infected, right? Anecdotal evidence like that. And that's the same thing that for COVID, it transmits best in close proximity. And we have anecdotal reports where people with COVID expose other people, but the other people don't get sick, right? And then also, like in this case for tuberculosis, we see outbreaks that happens in ships, in buses, in poorly ventilated classrooms, in bars. So we see that the patterns of these diseases are very similar. And my hypothesis is that COVID-19 is also predominantly a disease that's transmitted through aerosols. So I'll leave it there. Thank you.
Great. As we get the screen back, when we do, we'll be able to have Linsey Marr make her presentation.
So you should have the screen back already.
We are working on it. Jose, while we're waiting, I just ask you a question? What would you say is the biggest unknown, something that you would really like to know about the spread of COVID-19?
Oh, there's so many, so many things. But I mean, the issues related to the things like the viral dose and that kind of thing, and how the viruses are distributed in different aerosols. Those are very interesting. But I think Linsey is ready.
All right, next slide. The new CDC guidance came out on Monday. This is, they had changed it a couple of weeks ago, but it only lasted part of a day and then they pulled it back down. They've kind of described transmission in two main categories. One is close contact and the second is, they say COVID-19 can sometimes be spread by airborne transmission. These definitions are still resting on epidemiology, kind of like who gets the disease and what types of situations. Are they close or are they far away? But it doesn't really reflect what we understand about mechanisms, and understanding those mechanisms is important because that informs how we can best apply our interventions and slow this down. So what I want to point out here is that in their new definitions, airborne transmission is important in both cases. In the top, in close contact, they say respiratory droplets cause infection when they are inhaled. Well, if they're inhaled, we call them, they're small enough that we call them aerosols, and this is really short range airborne transmission. And then I did a little editing, took the liberty of writing on their webpage. COVID-19 commonly spreads by airborne transmission, not just can sometimes. I think they're a little too conservative just for reasons of historical bias against acknowledging this. Next slide. So when people are at close contact, there's 4 different ways that the disease can spread, either by direct contact, touching, or fomites, which are other objects that become contaminated, or as Dr. Jiminez discussed, these large ballistic droplets, or by inhaling aerosols. Next slide. The interventions that CDC now lists, I do want to say, are correct. These include distancing, covering your mouth and nose with a mask when around others, not just when you can't maintain distance. So this is really anytime you're indoors and there's other people around outside of your own household. washing your hands. We still, that can't hurt. Here's what they added: avoiding crowded indoor spaces and ensure indoor spaces are properly ventilated. So the fact that they now recognize airborne transmission means that these steps are, they have to do something, say something about these interventions. And let's see, those are the ones I wanted to highlight, kind of that avoid crowding indoor spaces and ensuring they're properly ventilated. And this goes along with Japan's 3 C's, which is avoiding close contact, avoiding crowds, and avoiding closed, poorly ventilated environments. Next slide. So this is an illustration showing kind of how these interventions actually work. One is source control. That's putting a mask on the person who's infected. On the left, you can see her respiratory plume. There's maybe one droplet, large blue droplet, and then hundreds of smaller aerosols. Those have spread throughout the room, the red dots. You can see some of them have settled on the floor and the droplets have settled nearby. The little red circular arrows indicate the possibility for those to be resuspended into air. Distancing in masks, we'll see the middle person move farther away, so she's out of that respiratory plume. We're going to put masks on the other 2 people, which will reduce the amount of virus they inhale from air. With ventilation and filtration, that dilutes the virus that's in these aerosols and those red dots. Number 4 is hygiene, washing your hands, cleaning the floor. Next slide. So now you can see we've moved the people apart, we've put masks on them, and there's far fewer aerosols in the air. Next slide. My group has been doing mask testing. Typically, we study survival of viruses in droplets and aerosols, but as the pandemic came about, we realized there was an importance of looking at efficacy of cloth masks that the public is wearing, and our lab is not able to work with this particular virus because of the high biosafety concerns. So we've taken these mannequin heads, we stick them in a chamber, we generate sodium chloride salt aerosols from a medical nebulizer. This is very similar to the NIOSH method. And then we measure what goes through the mouth of the opposite mannequin using an instrument called an aerodynamic particle sizer, which tells us how many aerosols are there and what size are they. And then we can put masks on either of the mannequins. On the right one, that would be for source control, and on the left one, that would be for protecting the wearer. And I'm showing an example here of some results. This is for a surgical mask. The black line shows the material filtration efficiency, and that's if we actually cut out a piece of the mask, we put it into a special holder, and we flow aerosols through it under very controlled conditions, like perfect conditions with no leakage. And you can see that even at those smaller sizes of 0.1 to 0.3 microns, which are the hardest to remove, this is where N95s have to achieve 95% removal. The surgical mask is getting better than 50% removal, which is not good enough for someone in healthcare who is, as part of their job, is regularly exposed to sick people. But for trying to reduce transmission, slow it at the population level, every little bit helps. And then you can see as we go to larger particle sizes, like 1 to 5 microns, our efficiency gets much better. And then if we look at kind of inward and outward protection, those are for the masks that are actually on the mannequins. And you can see that there's some leakage, so the efficiencies aren't as good. In general, we get better outward protection because those aerosols are kind of right close. We're talking about source control, putting a mask on someone who's infected, and you're blocking those right as they're coming out of their mouth at high velocities, and there's less opportunity for leakage. Next slide. I think that's all. Thanks.
Okay, now we'll move on to Shelly Miller. Thank you, Linsey.
Great, thanks a lot. Today I'll be covering really briefly 3 different ways to protect ourselves from airborne transmission in indoor environments: ventilation, air cleaners, and germicidal air disinfection. Next slide. So first we'll cover ventilation. Next slide. Building ventilation can be as effective as public health interventions. We are not sure what the actual ventilation rate should be for pandemics, and I'm going to discuss briefly what I think. An existing ventilation rate are most likely too low in many settings, and they may need to really be increased, which is what we've been trying to get the word out to people who are, running small businesses indoors or schools, etc. In the study that I show on the right was a really, really interesting modeling study of transmission of an airborne infectious disease in Hong Kong, the population of Hong Kong. And the pandemic starts with one person who's infected and the transmission happens indoors, very similar to a COVID. And what we see on the upper graph is the percentage of daily infections under a 1 air change per hour scenario in buildings that we have over 40% infected very quickly in the pandemic. Whereas if these buildings are then increased in their ventilation to 3, 5, and 7 air changes per hour, the percent of daily infection drops, as does the pandemic spreads out in time, which is what we need. And on the lower picture, what you see is that with very low ventilation, 100% of the people end up getting infected. But if you can increase your ventilation with outside air, we slowly see a decrease in the number of infected individuals. And when we get to upwards of 9 air changes per hour, almost nobody gets infected indoors. Next slide. What ventilation rate is needed is still an active question. We have not had the funding or the research capability to completely answer this question. But right now we're bounding the limits of 5 liters per second per person of outside air to 25 liters per second per person outside air. In a study of flu transmission in a dorm at the University of Maryland, what they discovered is that dorm rooms with 6 liters per second per person had low levels of acute respiratory infection transmission. Only 1 out of 11 residents got sick. In the low ventilation dorm, where we have 2 liters per second per person, almost half of the dorm members got sick. Next slide. In this study, in a university setting, where transmission of tuberculosis, at which we know as a completely obligate airborne transmission of an infectious disease happens, they had an outbreak of tuberculosis. And when they looked at the university buildings, we discovered that they were very poorly ventilated at 1.7 liters per second per person. And you'll see on the right, you can also detect the carbon dioxide levels in the buildings, and the squares with the straight line through them, those are the CO2 levels, and here the average level is around 1,200 in these buildings, and transmission was ongoing. And so they did a huge retrofit of the buildings and increased the ventilation substantially, which dropped the carbon dioxide indoors and brought the outbreak to a stop. So again, we're seeing 24 liters per second per person indoors and upwards of 6 liters per second per person. Right now, personally, I'm recommending 10 liters per second per person, although many buildings cannot achieve that yet. Next slide. Although I do want to add that if you end up dropping your occupancy indoors, you effectively provide more clean air per person in the building, and you're dropping the occupancy to reduce transmission in close contact. Let's talk about filtration. Next slide. The reason we talk about filtration is because if you cannot get enough clean outside air in your building, then you can supplement with engineering controls like air cleaners. The way you purchase an air cleaner is to figure out the size of the air cleaner you need to purchase to run in a particular space. We call this parameter that helps us understand what size of air cleaner the clean air delivery rate. The graph that I show here shows particles building up indoors as a function of time. And when you turn on your air cleaner and stop generating particles, so maybe an infectious person came into a restaurant, was talking and speaking loudly and then left, if you run your air cleaner, you will see that the airborne particle concentrations drop much more quickly than if you did not have your air cleaner in the room. And so this is why we are recommending air cleaners. Now, the clean air delivery rate is a certification standard provided by the Association of Home Appliance Manufacturers, or AAAR, and will tell you the size of the room that you can use them in. So this little certification I have here on the right is for 120 square feet, and it will provide 80% protection against all airborne particles. Next slide. So in a study we did with aerosolizing mycobacteria, which is a surrogate for tuberculosis, and fungi, which is a larger airborne bioaerosol, and larger bioaerosol representative aspergillosis or something like that, we saw you know, there are differences between air cleaners, but it doesn't matter what kind of bioaerosol you're treating. They all take them out of the air, if it's a small one or a big one, especially if they're a HEPA filter air cleaner, because that is how they are functioning. Over 99% of the particles of any size get removed in a HEPA air cleaner if it's manufactured correctly. Next slide. So the reason that you need to know what the cleaner delivery rate is because you need to know what size of room it will be effective in. So the air cleaner number 1 showed in the previous graph has a cleaner delivery rate of 100 CFM. It can clean 133 square foot room with an 8-foot ceiling. So can you click, because you'll get an animation. And then Air Cleaner 2 has a cleaner delivery rate of 140 cubic feet so that can only clean an 18 square foot room. And that is a real product on the market, which costs $700 and could barely clean your bathroom. Next slide, or next animation, yep. So you have to be really careful what kind of air cleaner you buy, which is why we recommend, you know, really making sure you know what you're doing. Next slide. My last topic is germicidal UV, of which I spent many years studying. I'm still one of the leading experts on this technology. Next slide. So one of the best ways to use germicidal UV is in the upper room air disinfection configuration, where you hang germicidal UV lamps on the wall and it disinfects the air above the people in the room. Next slide. And this will be an animation, so just keep clicking through, please. So some of the applications are in hospital settings where you might have, you know, unsuspected cases of infection in a waiting room or in an open ward or in a treatment room. And another couple of applications that I've been consulting for and recommending are homeless shelters and correctional facilities, where you're not sure who's infectious. You have a lot of people in that space. You don't probably have any ventilation provided, or you can't pay to get it upgraded. So you would use a germicidal UV technology. Next slide. This technology was first introduced by a team of physicians who were combating measles. Next animation. And in this paper, they discussed how they used UV to fight measles in schools. And in classrooms that were unirradiated, we saw a 50% transmission of measles, which is highly infectious, airborne disease. But in the irradiated classrooms, that dropped quite significantly. And the first sentence of the paper I love: the prevalence of respiratory infection during the season of indoor congregation suggests a natural relationship between ventilation and communicable disease. Now, this was written in the 1940s, and we're still not paying attention today. Next slide. Our work on upper room germicidal UV has been published by the CDC in this guideline on basic upper room ultraviolet germicidal radiation guidelines for healthcare settings. The guidelines are applicable for community settings as well. And in the graph to the upper right, you can see that the relationship between how much UV you add is reflected in the equivalent air exchange rate. So in our study with 5 lamp fixtures, we were able to add an astounding 17 air changes per hour of effective air disinfection with germicidal UV. In another paper that analyzed control technologies, they found among different engineering control measures, UV singling is the optimal strategy combined with effective isolation and vaccine interventions for containing airborne diseases. And I know that we're working on vaccine interventions. We're not there yet. So we can apply engineering controls to reduce transmission among our community now. I think that's all I have today. Next slide. That's it. Thanks.
Great. Okay, let me kick it off the questions and ask the panel. What do you see in the media, on social media? What is the biggest myth being perpetuated about COVID-19 transmission from an aerosol science perspective?
I have
Go ahead,
one.
Leslie. Yeah, sure.
That face shields are effective. Those are effective for large droplets, and that Dr. Jiminez described that kind of land on our eyes, nose, or mouth, but they don't help with aerosols because the aerosols can easily follow the airflow around. So I know that there are localities where a face shield is considered as an acceptable alternative to a mask, but they're really two different things.
Yeah. Shelly, if I can pick on you each for this one.
Yeah, I think what's critical to me is that people are saying if you're socially distanced, you don't need to wear a mask. And that is not true indoors. You absolutely need to wear a mask indoors, even if you're socially distanced, because aerosols don't care whether you're 6 feet away, 3 feet away, or 20 feet away. You can still inhale them. The concentration is higher the closer you get to the infected person, but guess what? You don't know who's infected because there are asymptomatic people in the space.
And Jose.
I mean, I would say something that's not very clear is how all these different things we're talking about are layers of protection. I encounter a lot of people who feel because I'm wearing a mask, I'm now protected. I don't need to keep my distance. It doesn't matter how many people I am with or for how long, whatever. And it doesn't work that way. The mask, as Professor Marr showed us, it reduces your exposure some, but if you spend 3 times more time, you have already made up for it. So we need to have masks and reduce duration and increase ventilation and do air cleaning and do all of these things together is what can keep us safe and doing as much outdoors as we can.
Okay. Linsey, I heard you talk about the 3 C's, but can I come back to you and ask you, what are the conditions do you think need to exist quickly when people are making a quick assessment? Is this a safe environment for me to be socializing, having a meal, that type of thing?
Meals, I will not go to a indoor restaurant for dining until this is over because there's even if you are at a distance, everybody has their mask, or most people have their masks off because they're eating. When have you ever walked into a restaurant and it's dead quiet? People go to restaurants to socialize. So there's always someone talking at each of the tables, and they might be talking loudly if it's loud in the restaurant so that they can be heard. You're there for a long time, so an hour or more. We know nothing about the ventilation in the restaurants. So that's a big no-no for me. I'm still ordering takeout at the same frequency to support local businesses. But in general, with the 3 C's, I look for, me personally, I want to maintain distance. If it looks crowded anywhere, I'm not going. I'll turn around, come back at a different time. And then the kind of closed, poorly ventilated environments, it's hard to tell, but if anything feels stuffy about it or you smell things, that would be an indication that the ventilation is insufficient.
Yeah, that was going to be the next question was, how, and maybe I'll go to you on this one, Shelly. How does we look, it was very interesting how you were talking about the different environments and how you can how they can be purified. But how does somebody make a quick distinction? You're stepping into a restaurant or a building or school or anywhere. What should you quickly be looking for, to determine whether there's good ventilation or not?
The first thing I'm looking for is whether they have windows or doors open. And, right now, of course, the weather is conducive to this in Colorado. When windows and doors are open in buildings, and that is critical. The second thing I look for is how many people are in the space, just as Linsey said, and are they all wearing masks? And if there's people in there that aren't wearing masks, I will leave. And I do think it's difficult for business owners to enforce mask wearing, but it also means that I'm not going to frequent that space if they're not doing that. And I think those are the 2 main things that I look for. And then, as Linsey said, if it feels hot and stuffy and there's no windows and no doors and too many people and people not wearing masks, it's a pretty critically dangerous situation. I think it's unfortunate we are not providing our small businesses with opportunities to assess their ventilation, purchase air cleaning, install air cleaning. They're relying on industry reps to sell them technology that may or may not work, and we're not providing them support to inform the public on how they're doing with their ventilation and supplemental air cleaning, and we need to provide that access to them.
Jose, let me pick on you for a second. What's the worst thing that you see occurring out there from an aerosol perspective related to COVID-19 spread? Put another way, what makes you cringe when you see it, either on television or when you're out in public?
Well, probably what Professor Marr and Miller were referring to, crowded bars with loud music, a lot of people, no masks, alcohol, so people, have even less control, talk closer. That really makes me cringe, that type of situation. And as Professor Miller said, I mean, I think it's unfortunate because there is a lot that could be done. There was a colleague of ours was saying we shouldn't close the bars. We should tell the bars that they can operate a stand in the park. People need to socialize. If you close the bar, they're going to meet at home and get infected that way. So there is all these adaptations that we could be doing and are not doing very well.
Okay. All right. Tell us about masks. Let's talk a little bit more about those. What, is there certain type of mask that's available to the general public that you would recommend? And as I noticed, the general mask you're talking about was 50% effective. What, what should people be looking for when they go out to either purchase, make, or otherwise wear a mask? And I'll just open it up to the group.
Yeah, my research group has been working on this. We've looked at a variety of homemade materials and a surgical mask, neck gaiters, and most of these are able to block around 50% or more of aerosols that are 1 to 2 microns and larger. For the ones that are smaller than 1 micron, their performance is not nearly as good. That's where the N95s do a lot better. But even though the virus itself is quite small, 0.1 microns, the aerosols that carry it are probably quite a bit larger than that. And so, it's not fair to compare a cloth mask to an N95. They have different intent purposes. An N95 is intended to protect a healthcare worker who's, as their job is interacting with people who are known to be infected. With the cloth mask, we're really trying to reduce and slow spread among the population, the general public, who are experiencing, most likely lower exposures possibly than in the hospital. But that said, fit is crucial. You can have the best mask in the world, and if it doesn't fit, the air will just short circuit around there, and it's not protecting you or others. And beyond that, in general, we look for materials with a tighter weave, and two layers at least of the material seems to do better. But it's really hard, beyond that, it's hard to tell. I've seen results that are all over the place. Surgical masks, there are many surgical masks that are quite good if you can get a good fit, but I've also seen a couple that don't perform well. So this is an area where I think it would be great to have some kind of, and there are various independent academic labs who are evaluating this, but it may be time to start thinking about some kind of national certification standardization program for testing masks for consumer use outside of the healthcare setting.
What do you have to say to the people that wear their mask down below their nose?
It's like wearing your underwear that's not fully on. Yeah. And then I do want to say also that, I lost my train of thought. I think, I'm sure Dr. Jiminez has something to add here.
Yeah.
I have a couple things to add too after Jose. Okay.
You're on mute, Jose.
I wanted to add a couple of things onto what Dr. Marr said, which is that in talking with the research team at my university who's studying masks, Dr. Vance, the surgical masks that are 3-ply are working the best because they have a layer internal to the 2 outer layers that have an effective charge that helps remove particles better. So I make sure I buy 3-ply surgical masks. Last night was my first aircraft flight since March, and I wore a double mask with 1 surgical mask, and I purchased a KN95 that was, I saw the test sheet, it was made by a company I knew, and I bought it, and I wore that double mask, and my goggles, I looked ridiculous. It was very uncomfortable because there were tons of people around me, but I'm hoping that it worked out, and I moved when people were talking.
Yeah. Let me ask another question that came in. how would you evaluate, or what questions would you ask of a motel or hotel about their ventilation if you had to travel or stay someplace other than your home? You walk up to the desk, you ask questions, and maybe we'll go to Jose to start on this one, and you feel free to go on about the mask if you want as well.
I mean, I just have a quick thought. I mean, I haven't traveled since the pandemic, so I haven't thought about the question a lot, but this type of motel where basically you have your window and your room, and your room is totally disconnected, the air is totally disconnected from other rooms, actually looks very good. Any other hotel where you could have more air sharing makes me a little more worried, but perhaps Professor Miller or Marr know more than I do about hotel ventilation.
No, I think you've
Anyone
hit
else?
on the key points, which is that I have stayed in a couple of hotels since the pandemic, and those have been single rooms with, you know, with an internal air conditioning and heating, but no ducted ventilation. There are hotels that have that, although to be clear, in the literature, we have not seen any transmission of SARS-CoV-2 through the ductwork and infecting people in other rooms connected to the same ventilation system. So just to be clear, the potential is there, but we haven't seen that happen.
I'd like to add that I would opt for motels where there's no indoor hallways, and you can just go from outdoors straight to your room and not have to pass through indoor hallways, elevators, lobbies, and things like that.
What about riding in cars? I mean, obviously, if you're around just relatives, but it seems pretty obvious, but let me nonetheless ask it, but how dangerous is that to be riding in cars with groups of 3 or 4 people and maybe you don't know, like getting in a cab or getting an Uber?
If I may, it can be quite dangerous. And I've done an experiment. So this is an instrument that measures carbon dioxide, which is basically how much exhaled air there is in the room. And with this reading, about 5% of the air I'm breathing it for the second time. And it's just mine, so it's okay. But when I took this with my family in a car ride, and we had the windows closed and the air was recirculating, and very quickly we got to 4,000 parts per million, which that means, I don't know, like more than 10% of the air that we were breathing it for the second time. And if you are sharing now that air with other people that could be infected, that's a dangerous situation. Now, if you open the windows or if you put the car ventilation to take air from the outdoors, it went down really quickly. So cars can be safe, just open your windows or have high ventilation from the outside.
Okay. All right, this isn't meant to be political, but I think it's just something that all of us can identify with. Last Tuesday during the debate, Joe Biden and Donald Trump were, I guess, about 12 feet apart. Let's presume for a second that President Trump might have been infected at the time. How at risk was Joe Biden under those circumstances from an aerosol perspective?
None of us want to get hate Twitter.
Sorry.
But
Okay,
I can comment. The one thing I want to comment on is the more people in a space without a mask, the more dangerous it is. And so looking at a space and seeing, you know, multiple people in that space without masks makes the situation more dangerous for everybody. Now you're in an auditorium, the occupancy is reduced, the auditorium is well ventilated, I am sure, with good recirculation and filters, although we don't know. That would be a wonderful question for the commission to tell us every time there's a debate. But I would say the main comment is so many people without masks was concerning to me.
Did those shields last night during the vice presidential, would those do anything? No.
I think all of us have commented in public that, yeah, they were decoration at best, I think. I mean, maybe they did a little bit by deflecting the air, but really, I mean, I argued that they're really, by doing things like that, they're setting a bad example. They're giving an impression that you can talk indoors for a long time, and as long as you keep your distance, you're safe. That's what they are communicating, and that is not safe, right? Especially in a room that apparently it wasn't extremely well ventilated, right? I mean, it was probably not high risk, but I think it was a bad example. That would be my take.
If I could add, early on in the pandemic, we did not, the public, the community did not know how really this disease was being transmitted. Unfortunately, there are world leaders who knew early on that it was airborne and failed to tell the public. However, so we were all washing our groceries and spraying down surfaces and putting up plexiglass barriers and trying to figure out what's going on. Now we know predominant aerosol inhalation transmission is happening to drive this. And so now we know what we can do differently. And so continuing to use cleaning of surfaces and putting up plexiglass barriers as a method of control is more like theater now. Before we didn't know. It's completely understandable we were doing that, but now we know more and we should be doing stuff differently.
Okay. A couple more. Let's say you have to be indoors, you can't avoid it, and there's with a sizable crowd. You get into an auditorium, you get into a grocery store, whatever it might be. What knowing you're going to be in a crowd, knowing you're at risk, what can you do when you're in that environment to limit that risk as much as you can? We'll go to Linsey since you haven't talked a little bit.
Yeah, I would say to maintain distance as much as possible and get out of there as quickly as possible.
Anyone else on that one?
Go first thing in the morning. There tend to be, in most places, there is very few people first thing in the morning, and there is no virus left in the air from the previous day, although it has been ventilated or has decayed. So many times I've had to go to the dentist a couple of times due to some urgent thing, and I always, only the first appointment in the morning. That's the only time I would take. Okay.
Just a couple rapid fire ones. Movie theaters. What are your thoughts? I see a lot of commercials for movies now coming to theaters. Good idea, bad idea, and why?
I think for me personally, it's an unnecessary risk. It's not an essential item for me. You're sitting there for 2 hours. It's true, people aren't talking. Hopefully they're distanced. Hopefully they're wearing masks, but I'm willing to wait to see it when it comes out, and I can watch it at home.
Gymnasiums. I'll pick on you, Shelly.
I visited my local gymnasium to see what they were doing, and it does look like a reasonable situation. But again, for me, they're doing a lot. They're enforcing mask wearing. They probably have good ventilation, but for me, it's right now an unnecessary risk that I decided I'm not going to take on, and I asked them to suspend my membership yesterday.
So I'm a regular gym goer, and I've worked carefully with the owner of our gym. We are very fortunate because it is like a warehouse, and we can have 10 people in there with at least 10 feet between people. We have at least four large garage doors on both sides, and so we open up all those, and it's basically like being outside. And so I think if you're fortunate enough to have a facility like that, it can be low risk, but I realize that that's not common.
Okay, last one. Outdoor football games. The Big Ten, Pac-10, ACC, they're all going to be starting up games, or some of them already have. Under what conditions would you be comfortable at an outdoor football game, if at all? Jose.
So there is actually some data from a soccer match in Germany where there were several tens of thousands of people, and there are measurements of CO2 which are not very high. So I would say it's not a very high risk in terms of inhalation, except for the fact that you probably cannot keep distance. If you could keep your distance, then it wouldn't be too bad. I mean, also I guess there is another risk factor, which is that if people start yelling or start making a lot of noise, that's gonna again increase the aerosols. I guess I feel like Professor Marr about the movie theaters. You're certainly not gonna find me at a football match. It's not the highest risk activity I can think of, but it has some risk.
Yeah. Okay. And let me just do this one last thing is and I've probably asked it in a different way, but what's the one question that people don't think to ask that they should be? And maybe I'll go through each of you. And start with you, Shelly, just because you're on my left on my screen. What's the one question that people should be asking of themselves, thinking about as they go about their daily lives as it relates to contracting, being exposed to COVID-19 as it relates to aerosol science?
Well, I would like to mention briefly that we really need to be thinking about our priorities of where we want to expend our energy to minimize risk and where we want to take on risk. So the fact that we have not invested enough to get our schools open is heartbreaking to me. In fact, but yet I can go and get groceries and go to Target and do all of these important essential activities, but my kids can't go to school. It's just wrong. And we should be investing our time and resources in that venue, which we can do safely and lowering the risk. I think people need to consider, how do I lower my own personal everyday risk? So Linsey has decided to invest time in making sure the gym is low risk for her. Mine is like, I did have to go to my daughter's volleyball game indoors. How do I make that less risky? And so we all have to figure out where we want to spend our time that's important and reduce our risk indoors against aerosol transmission.
Thank you. Jose, I'm going to pick on you next, and then I'll finish up with Linsey. One question that people should be asking themselves, one thing they should be particularly vigilant about as they try to avoid the COVID-19.
I think the question would be can I do this outdoors? And be flexible with the answer. It's like, I'm from Spain, which has a mild climate, but people tell me when I tell them that, it's like, oh, it's too cold. It will be too cold and so then I tell them about 1910, the winter in New York and Boston, there was an epidemic of tuberculosis, and they did the schools outdoors. And actually, the kids were more awake, and it was a good experience. So if they can do that in those winters, most places can do that a lot of the time for a lot of activities. We have much better coats and Gore-Tex and whatever now. So can you do it outdoors? Can you organize it? Do it at a different time, do it however it needs to be so you can do it outdoors.
Okay, Linsey, you get the last word. One thing people should really be thinking about, asking themselves as they try to avoid COVID-19. Maybe now, even as Jose was talking about, thinking about it as more and more activities are moving indoors over the winter months here in the U.S.
Yeah, my question has been like for the airlines, what do you do if someone's not wearing a mask?
Okay. What's your answer? Somebody's not wearing a mask. What do you do? Jump out of the, if you don't, presuming you don't have a parachute.
Well, that's my question to the business, whoever's in charge of that situation.
Yeah. Okay. All right. Great. Fair enough. All right. Well, thank you again to the panel. I really appreciate you taking the time, giving us your thoughts and wisdom about aerosol science and its relation to COVID-19. And thanks, especially to our presenters, but also everybody who's chosen to join us today. If you want more information about AAAR, it can be found on the organization's website. If you have interest in following up with any of the panelists, you can reach out through the invitation that we extended to you about this event or through the AAAR website. So thank you again. Everyone, please stay safe. Take the advice that you heard today and have a great day.
Thanks, Jim.
Thank you.